I'm Deborah Satz. As you know, I'm an instructor for the class along with Paul Brest, and many of you have heard this introduction before, but since we have drop-ins and we post online each session, it's really important that we continue to frame what this class is about and what its rationale is. So I'll be brief, briefer than usual, but I will go through again why we're doing this. So, not surprising to any of you, deep disagreement pervades our democracy, from arguments about immigration, taxation, foreign policy, recent events in Venezuela, the Middle East crisis, to the function of very selective institutions like Stanford, and the value of free speech itself. Such disagreement is by itself not a cause for concern. We should expect that in a democratic society, one not ruled by a king or an autocrat, that is a society based on the equal freedom and status of its members, reasonable people will disagree about many things. Some of the deepest questions of morality, religion, and value are hard to think through. Even people who are well-motivated and conscientious will answer questions pertaining to these matters in different ways, perhaps because of their different life experiences, or because the facts are hard to pin down and admit of various interpretations, or because they make different trade-offs among competing values. The same is true of more mundane issues of policy. In other words, disagreement is a feature of democratic society and not a bug. But not all disagreements are reasonable or productive. Sometimes people fail to consider inconvenient facts and close their minds to evidence, and all too frequently on online platforms, a culture of incivility prevails with respect to those with whom we disagree. Note that by incivility, I'm not talking about politeness. I'm talking about the failure to treat other people with respect simply because they hold different views on matters we care about. This uncivil closing of the mind is especially a concern for a university. The fundamental mission of the university, the pursuit of knowledge, absolutely depends on the free exchange of ideas and an openness to question free received opinions. History shows us how often we get things wrong, how vulnerable we are to narrow-minded provincialism, and, to put it bluntly, we're capable of monumental error. And I frequently bring up the cases that John Stuart Mill reminds us in On Liberty, the cases of Socrates and Jesus, the first executed for impiety and immorality, the second for blasphemy. We don't have a great track record. It's because we felt this mission is under stress, the pursuit of knowledge, that we launched this course. Each class features a different topic and has guest speakers presenting, as you know, for about 10 to 12 minutes each. And then they join us for a conversation on stage. For today, after I conclude, Paul is going to introduce the speakers, and then I'll moderate after the speakers return to their seats. I'll moderate the discussion. And this class is today's class, a really great example of the issues of democracy and disagreement. We'll explore contested evidence, the need for policy, the interpretation of evidence, including decisions that have to be made in real time under conditions of uncertainty with high stakes, even in the best of circumstances. Productive, effective disagreement is hard. In addition to having an open mind, you have to be able to listen to others, you have to have knowledge of facts and values at stake in the issue, and we very much hope this class engages you and deepens your appreciation for the complexity around many issues. And with that, I'll turn it over to Paul. Thank you.
So I have the pleasure of introducing our two guests today. Stephen Macedo is Laurance S. Rockefeller Professor of Politics at the University Center for Human Values at Princeton University, and together with his Princeton colleague, Francis Lee, he's author of the very recent book, In COVID's Wake, How Our Politics Failed Us, which you'll hear much about today, and I believe the book will be on sale by the Stanford bookstore outside after this event. Among his several other books, two are particularly relevant to this course and also to College 102, which a number of you are taking. Liberal Virtues, Citizenship, Virtue, and Community in Liberal Constitutionalism, and Democracy at Risk, How Political Choices Undermine Citizen Participation and What We Can Do About It. The second one is co-authored with Deborah's collaborator, Margaret Levy, and my Swarthmore classmate, Bob Putnam, among others. Professor Macedo's current research concerns the pressure on social justice exerted by various forms of globalization and the problems raised by social media companies and the dangers of government efforts to police misinformation. Sara Cody is a physician, epidemiologist, and public health official. A native of Palo Alto, she majored in biology at Stanford and received her MD from Yale School of Medicine. She then returned to Stanford for her residency, and this was followed by a fellowship in epidemiology at CDC. Dr. Cody joined the Public Health Department of Santa Clara County in 1998 and became Santa Clara County's health officer in 2013. When the COVID pandemic reached the United States in 2020, she advocated for measures that would limit its spread, including a contact tracing system and requirements that residents shelter in place. Many of you will recall the uncertainties that surrounded not just the origin, but the very dynamics of the COVID pandemic, how the virus was propagated, and what measures were effective in cabining it. Like many of her counterparts throughout the nation, Dr. Cody was required to engage in decision-making in conditions of great uncertainty, and today's discussion will critically examine some of those decisions in retrospect. And now, if you would put up the polling question, and we'll see how the poll goes. We'll repeat the question at the end of the discussion, and as Deborah has reminded us often, even when minds are not moved, we hope the class will give you an appreciation for the reasoning behind the views you accept or reject. So the question is, were most of the COVID restrictions necessary and beneficial in retrospect? 72% or 73% say yes. 23% say no. Okay. And now, I'll turn it over to our speakers.
Thank you so much for having me here. It's a real pleasure, and I'm looking forward to a robust discussion. Professor Macedo and I just had the chance to meet each other, so we don't have the benefit of knowing each other well, but I think we'll have a great discussion. So I am going to speak about my experience as one local health official in one county, in one state, in one country during a global pandemic. So I'm going to go really close to the ground and give you a sense of what I experienced and how I made the decisions that I did. So first, just for a bit of context, that's Santa Clara County there on the edge of the Pacific, the red pin. And way across the ocean, you can see two dots. The red dot there is Wuhan in Hubei province, and below that is a blue dot, and that's Guangdong province. And the reason that I wanted you to see that is that in 2003, during SARS-1, which emerged in Guangdong province, Santa Clara County recorded 2 of the 8 cases in the entire US. And that's when I was the communicable disease controller for the county. So we were kind of expecting and anticipating that we might see early activity when a novel coronavirus emerged in Wuhan. This is Santa Clara County, home to 2 million residents, the 6th largest county in the state and the largest in Northern California. And Santa Clara County is very demographically diverse by pretty much any measure you can think of. Over 40% of people living in the county were born outside the country. Over 50% speak a language other than English in their home. And close to 100 different languages and dialects are spoken across the population. And as you know, the county is also home to Stanford, Silicon Valley, and many large high-tech companies, which is just to illustrate that there is a lot of travel between Santa Clara County and Asia, particularly China, and that's for both professional and personal reasons. And until May of 2025, I served as the physician health officer for Santa Clara County, which means that everyone in the county was essentially my patient. And this is because in California, extraordinary power, authority, and responsibility is granted to local health officers to safeguard the public's health. In our very federated systems, states have the locus of this public health power, but in a decentralized state like California, that power is further devolved to the counties, and a lot of it rests with the county health officer. So California legislators over time have passed a number of laws. They're both broad and vague that give responsibility and authority to health officers to protect the public from communicable disease and other ills. So this is one such example I wanted to share from the Health and Safety Code. And it essentially says that health officer, if you know there's a communicable disease that exists, you shall take measures as may be necessary to prevent the spread of disease. And I want to focus on the word shall. So it's not a you can do something if you feel like it, it's a you shall do something if you know that there's a problem. So with that context, I just wanted to walk you through how the pandemic unfolded here in Santa Clara County, for those of you who weren't in the county in early 2020. By mid-January, we had really started to worry in earnest. We knew that people in Wuhan had died from some severe pneumonia. The infection had spread to a number of other countries, including South Korea, Japan, and Thailand. And then a short time later, on January 7th, the US reported first case in Washington state. A few days after that, a traveler, a Santa Clara County resident, returned from Wuhan and was ill. Unfortunately, the traveler wasn't tested until a few days later, January 27th. Recall that was the time when there was one lab, the CDC lab, that ran a test. And it was this enormous bureaucratic process to get a single sample tested, and quite a lot of work and quite a lot of time. We didn't receive those results until January 31. And later that day, we announced our first case of this novel coronavirus. And this was the 3rd case in California and the 7th in the US. Then 48 hours after that, we had our second travel-associated case. And at that time, you may remember, there were, as I said, very few tests around, but our phones were ringing off the hook with calls from anxious physicians and others with people who were ill who had returned from travel, but we couldn't test them because they didn't meet this very narrow case definition. It was a classic case of don't look, won't find. So, but despite this, despite the fact that we weren't really looking anywhere in the US, the word on the street and what the federal and state health authorities were saying was that the risk was low. But we wondered, what is the risk? And we wondered, were we different in Santa Clara County? a colleague and I stuck a big wall post-it up in a conference room and wrote down some numbers that we grabbed from the CDC website, as well as our numbers. And we just, even though the numbers were small, we noticed a couple things. First, our county represented just 0.6% of the population in the country, but we already had 5% of the PUIs, or persons under investigation, and we already had 18% of the positives in the country. So really small, but we didn't have a whole lot to go on. Finally, after the first week of February, our public health lab, part of the lab response network, is told that we can start running the CDC test. But very quickly, our lab director told me, and this was experienced by every other lab that it tried, that the test wasn't working. There was a control that was positive and not supposed to be. And so for the whole of February, the next very long 2.5 weeks, we really were in the dark. We couldn't test, and so we couldn't see, and so we didn't really know what was going on. Finally, at the end of the month, we're told that we could just use the probes that we had that were working and forget about the probe that wasn't working, and we were off to the races, but with a lot of lost time. So the very second sample that we ran in our lab tested positive. This was a woman in her 60s. She'd been in the ICU for almost a week. She didn't meet the testing criteria, but we bucked the guidance and tested her anyway. And she represented the first case of community transmission in the county and just the third case in the US. And I was extremely nervous about how I was going to talk about this, because this was so different than what everyone had been saying. And I needed to say that the risk was unknown. So I thought really carefully. I scripted my comments, and I was quite nervous. That's me looking nervous. And I did my spiel, and I thought I'd nailed it. We got a shout out on Rachel Maddow about clear, honest communication, and we were feeling great. And then a few days later, my husband was on a work trip in Washington, D.C., opened his laptop, and this was the landing page of the Washington Post. And it turns out that I had wanted to give the public things to do. I was telling them something that I thought was scary, and so I said, please practice not touching your eyes, nose, and mouth. That was my action item. But I couldn't get the pages to turn, and I unconsciously licked my finger not once, but 3 times. And then it went viral, literally around the globe, India, UK, everywhere. So this is just to illustrate that being a health officer was it was a humbling experience. A helpful colleague sent me this. Now, it's early March. We saw a lot of activity in early March. Our lab was just able to test 1 to 2 dozen samples a day. This again is for a population of 2 million people. We decided to take 100 of those tests and set them aside to do a small surveillance study in our county clinics to test people who were negative for influenza, see if they were positive for COVID, to give us a sense of what the prevalence might be. This is a summary of what we found in early March, and I want to walk you through this. Unbeknownst to us at the time, of course, a county resident had already died on February 6th. This was the first death in the US, but not discovered to be such until April. Then you see nothing happening in February where we're not testing, and you can see case counts beginning to grow the first 2 weeks of March. In response to that, on Monday, March 9, I issued my first health officer order to the whole population, prohibiting gatherings greater than 1,000. By that Thursday, parents, teachers, and school administrators, the din about the safety in schools had reached fever pitch, and all 32 school superintendents in the county closed their schools on the 12th. The next day, because case counts were growing so quickly and this felt quite out of control, I issued another order to prohibit gatherings greater than 100. And during this time, we're watching what's happening in Italy, and we're learning more about the virus. And I remember a particular report in late February, a large case series from China, where they estimated the case fatality ratio to be 2.3%. And you could see that the risk of deaths picked up quite a bit with age, starting after age 50 and really accelerating after age 70 and 80. The next day, we got the results back from that rapid surveillance test, and 11% of the patients that were negative for flu were positive for COVID. This is quite a bit much more than I had anticipated. The following day was a Sunday, and I got a text from my dear friend and colleague, Tomas Aragon, who was serving as the health officer in San Francisco, and he wanted to talk about gathering size. We were confusing everyone in the Bay Area. Every county had a different size. It wasn't really not great for consistency communicating with the public. But Tomas and I quickly realized we were having the wrong conversation and we needed to be talking about shelter in place. We had 123 cases and 2 deaths in Santa Clara County, which was far more than any of the other Bay Area counties. But when we were looking at northern Italy and Santa Clara County, and we were almost exactly like Italy, but just 2 weeks behind in our Santa Clara County data. I also want to mention just the context at the time. Very severe shortage of personal protective equipment, most notably masks. In many of our hospitals, each healthcare provider would use a single mask for the week before getting a new mask. There just weren't any masks available. No vaccine on the horizon, no treatments, and really only an emerging understanding of how the virus behaved at that point. The day progressed. By 5 o'clock, we had 5 of our other Bay Area counties on the line. Along with our county council, we drafted the first health officer order in the country to ask the population to shelter in place. And by that evening, we had like all the representatives from all the counties on a large conference call to finalize the plan. The next day, we issued this order. They were identical orders. We all issued them at the same time. I think by 11 o'clock, we had finalized them. We had a press conference at noon, and the order became effective at midnight. So from the time when we first started discussing it to when we announced it was just a little over 24 hours. I want to say a little bit about, this is the press conference where we announced it, about this decision. It felt very clear to me, the way the laws are written in California, that this was my responsibility as health officer. I didn't see any other tools to protect the public. And what I knew from what we were learning, gathering information from around the world, is that people were going to die. And this was the only tool that we had to stop, to try to prevent death. I also, quite absurdly, had this idea that this was just going to be temporary. It would probably just be a few weeks, and then I didn't know what. But I assumed that somebody must have had a plan up their sleeve somewhere. That's sort of the level of how surreal it all was and it all felt. So we stood up there and announced it and wondered, if we just stood at our podium and said, and now you all must shelter in place at the strike of midnight, we wondered what would the population actually do. Well, in the Bay Area, people stayed home. This is downtown San Jose. This is the East Bay Freeway in the middle of a day on a weekday. This is the entrance to San Francisco International Airport. And there were other impacts as well. We had protesters that began showing up to our home first in the afternoons with sidewalk chalk, and later progressing to evening loud weekly protests outside the home with megaphones. We had a security detail. I had death threats. But we also had tremendous support from the community and from county leadership. The overwhelming number of people, the overwhelming response that we got was quite positive. This was one of my favorites. I wished our county executive would heed the cry. He never did. But these are just, this is just a moment in time. Cumulative death rates during the time where it was mostly the non-pharmaceutical intervention, so from the beginning of the pandemic through halfway through 2021. And you can see that the death rates in Santa Clara County are about half that in the country and well below that of the rest of California. Very heterogeneous in California. It was by all means not the same. And I think maybe just in the interest of time, I'm not going to discuss these reflections. I'll turn it over to Steve Macedo. And thank you so much for your time.
Well, thank you very much, and I'm delighted to be able to speak here with Sara, and appreciate the invitation very much. I'm not here to criticize anything that was done by those who were making decisions at the time. Were I making the decisions at the time, I have no idea what I would have done. I might have done exactly the same thing. And I applaud those who were in the fray and engaged in public service and facing up to such horrible threats as Sara and many others did. What I've done with my co-author is try to do a retrospective in hindsight. How did it go? And were there things that were known about pandemic preparedness and how to deal with pandemics that perhaps we didn't pay as much attention as we should have? So the book is a retrospective, and I'm just going to give you a very brief overview of parts of it as is relevant to the question here. Now, in some ways, we take the book to be a wider commentary on the state of democracy in America, which is extremely polarized due to the affective polarization across party lines. And we do think that deliberation around COVID was handicapped and undermined by the extent of hatred, really, across partisan lines. People would not listen to arguments if they came from the other side of the political spectrum, and I think that our public deliberations around COVID policy were degraded by that. And I do think that educated elites were part of that not enough attention was paid to those who dissented from COVID policy. And in fact, I'll say, including here at Stanford, in my opinion. But I'm going to skip over a good deal of this wider institutional comments. Now, as Sara said, it was a terrible pandemic. It was the worst pandemic in a century. And there's no gainsaying that. In Italy, it was terrible. In New York, it was terrible. The worst flu since the Great Flu of 1918 to 1919. But the policy response was also extraordinary. Never before in human history have we tried to suppress a virus on this scale. By early April 2020, half the world's population was living in some form of lockdown, 3.9 billion people, an unprecedented response. And of course, mistakes were made, but we need an honest and critical reassessment. And that's what I want to just give you very briefly here in the 10 minutes that are available to me. So there were decades of pandemic planning before COVID, and it's worth paying attention to what they had to say. So in November 2019, the World Health Organization put out an update of its pandemic planning documents, and it emphasized the uncertainty and the low or very low quality of evidence for the non-pharmaceutical interventions, that is school closures, workplace closures, restrictions on gathering sizes, mask mandates, social distancing measures of all kinds, everything we did before drugs and the vaccines were available. These pre-COVID pandemic planning documents examined the evidence for the efficacy of all of these measures for 2 decades before COVID. And they the overall assessment there is that the quality of evidence for their effectiveness is very low. And as we'll see too, they are emphatic that the costs will be very high. But in any case, the measures not recommended by the World Health Organization's 2019 document include contact tracing, quarantine of exposed individuals, entry and exit screening, and border closures, because these were judged to be not sufficiently effective, and extremely costly, disruptive to people's lives. School closures, this document said, could have a major impact on the safety, health, and nutrition of children in lower income families in particular, and so potentially not cost effective. And it argued that school closures raised major ethical issues, for families and communities. Johns Hopkins University, likewise, the summer of 2019, just a few months before COVID, issued the same kinds of doubtful assessments of the efficacy of these non-pharmaceutical measures, and said it's important to communicate to political leaders the absence of evidence surrounding many non-pharmaceutical interventions and the adverse consequences that may follow from them. And that Johns Hopkins document said this is especially important for scientists and public health officials to communicate this uncertainty, because public officials will have an incentive to use these measures to show that they're in charge, to show that they're taking it seriously, to show that they're taking firm action. In other words, they'll have incentives to implement these measures for political reasons rather than for because they're backed by sound evidence. The UK in 2011, another such planning document said, it almost certainly will not be possible to contain or eradicate a new virus in its country of origin or on arrival to the UK. The expectation must be that the virus will inevitably spread, and that any local measures taken to disrupt or reduce the spread are likely to have very limited or partial success at the national level and cannot be relied upon even as a way to buy time. Professor Robert Dingwall, who was on the planning group that devised these principles, said during COVID, close attention was paid to whether we might shut borders, restrict internal travel, and shut schools, but we decided these things were unworkable or at worst counterproductive. He concluded as well, we had the right pandemic plan in place, but during COVID, politicians lost their nerves and ignored it. The American Civil Liberties Union finally in 2008 said this in response to other pandemic plans that were being devised by the Bush administration at that time. American history contains vivid reminders that grafting the values of law enforcement and national security onto public health is both ineffective and dangerous. Too often, fears aroused by disease and epidemics have justified abuses of state power. Coercion and brute force gratuitously breed public distrust and encourage people most in need of care to evade public health authorities. Effective preventive strategies that rely on voluntary participation do work. As long as public health officials are working to help people rather than punish them, people are likely to engage willingly in any and all efforts to keep their families and communities healthy. And finally, minorities and other socially disadvantaged populations tend to bear the brunt of tough public health measures. The American Civil Liberties Union was entirely silent during COVID. Now, there were mathematical modelers who gained influence under the Bush administration who were more optimistic about these measures based on projections, modeled projections of how social interactions would change. And just a quote from one of these documents from 2006, the pandemic influenza plan, modeling supports school closures as an effective means of reducing overall attack rates. The modelers saw school closures as the most important of the measures to try to reduce infection rates from a new virus. The value of this intervention is maximized if school closure occurs early in the course of a community outbreak. Just how early is early enough is not easy to say. The Institute of Medicine examined these modeled projections, assembled a team of experts led by Dr. Adel Mahmoud, who was actually visiting at Princeton at the time, and they concluded that the empirical evidence for these optimistic projections was not supported by the data. They judged, for example, that total mortality in the 1918 pandemic was only weakly associated with the interventions that some cities took and that others did not, and that the non-pharmaceutical measures implemented in 1918 do not explain much variation across cities. They did not endorse the use of NPIs for future pandemics because it's almost possible to say that the interventions, either individually or in combination, will be effective. And they warned as well that leaders might implement NPIs for political reasons, and the public must be informed about the costs and the weak evidence for the efficacy of these measures. And Dr. D.A. Henderson, finally, who led the effort globally to eradicate smallpox, was active at the time of these original model projections and was subsequently dean of the Johns Hopkins University School of Public Health. He joined in being skeptical about the efficacy of these kinds of measures that we implemented during COVID. He said in 2006, as experience shows, there's no basis for recommending quarantine of either groups or individuals. The problems in implementing such measures are formidable, and secondary effects such as loss of public trust in government are likely to be considerable. So that, I think, is, there were differences of opinion, but there was considerable skepticism about the evidentiary basis for these various non-pharmaceutical measures, lockdown, school closures, and so on. And there was warning that they would be extremely costly in terms of general social well-being and including measures of public health. So policy turned on a dime in March 2020. In spite of these measures, lockdown policies were adopted widely across the world. The Wuhan lockdown occurred on January 22nd, 2020, the largest quarantine in human history up to that point, 60 million people. There was a lot of skepticism that greeted the Wuhan lockdown from Dr. Anthony Fauci and many others. That's something, he said, I don't think we could possibly do in the United States. I can't imagine shutting down New York or Los Angeles, but the judgment on the part of the Chinese health authorities is that this is something that, in fact, is going to help in containing it. Whether it does or does not is really open to question, because historically, when you shut things down, it doesn't have a major effect. And there were many other leading scientists that echoed these sentiments in the middle of March 2020. Dr. Michael Osterholm from the University of Minnesota said people are just following each other off the edge of a cliff because they're not thinking. Dr. Tom Frieden, the former head of the CDC, echoed these skeptical measures. The lockdown measures could be worse than COVID, he said. And others, Dr. Justin Lesler of Johns Hopkins and David Katz of Yale, and others in op-eds in the New York Times and the Washington Post, which we quote in the book. But the World Health Organization sent a mission to China for a week. They judged after a week there, under the tutelage of the Chinese government, that the Chinese efforts had been successful and that the virus had been suppressed, and that the entire world should follow the Chinese strategy of severe lockdown measures. Aggressive case identification, extreme social distancing. The World Health Organization team said this can work in any setting, in spite of the fact, of course, there were mandatory apps and surveillance measures available to the Chinese government, which were not going to be used in other parts of the world. There was a 3.4% prediction or assessment of the case fatality rate at that point. It was known to be way too high, but that frightened people as well. And then, of course, a famous Report 9 from Imperial College London, based on modeled projections by Dr. Neil M. Ferguson, who had a track record of overestimating the mortality of previous pandemics, said that absent extreme and sustained suppression measures, there would be 2.2 million dead from COVID in the United States by August of 2020. And so that date was when the President Trump had a news conference, and schools had already been shut down across the country, but that was a major turning and inflection point. To really, to dispense with the decades of pre-COVID pandemic planning and adopt, in effect, the Chinese strategy. Now, there were dissenters, including Jay Bhattacharya here at Stanford with others, who argued for policies that were similar to what Michael Osterholm and others argued for in March. Let's focus protection of the vulnerable. The costs of shutting down the whole society, keeping kids out of school, et cetera, will be extremely costly. Better to focus on those who are at highest risk and concentrate testing and social distancing to protect them. Maybe they were right, maybe they were wrong, but they deserved a respectful hearing, which I don't think they got. Dr. Francis Collins, the director of the National Institutes of Health, emailed Dr. Fauci and others saying, the proposal from the three fringe epidemiologists seems to be getting a lot of attention. There needs to be a quick and devastating published takedown of its premises. I mean, in effect, come May 2020, we declared war on COVID, and as in previous wars, dissent was unwelcome. Dissent was stigmatized, and I think the debate was cut off prematurely. And that was a major problem here. It's not that we made mistakes early on, but that we failed to learn from the experience of others. Europeans reopened their schools in many cases in April and May without incident. We didn't learn about that. It was not reported in the media. In any case, there was intolerance of dissent, I believe, during COVID. So just very quickly, what happened? The governors made the decisions, local public health officials, but states diverged widely in their response to COVID. I'm just going to go very quickly through this. Democratic states closed schools earlier and longer. And indeed, across the whole suite of non-pharmaceutical measures, there was a big partisan divergence, with Democratic states keeping their lockdown measures in place much longer than Republican states. All schools closed, but many schools in Republican states, most schools in Republican states were reopened in the fall of 2020, as were European schools, by the way. So if you look at state partisanship and school closures, Democratic states on the right, very strong partisan relationship between partisanship and school closures, Democratic vote and school closures. Overall stringency, Oxford put out this overall stringency index for non-pharmaceutical measures, the whole list of things, and they rated governments around the world very usefully in terms of the stringency of all of these lockdowns, restrictions on gatherings, stay-at-home orders, school closures, and so on. So if you look at overall all the pandemic restrictions, strong relationship between Democratic vote for president and the stringency of the pandemic measures, District of Columbia on the right, North Dakota, Wyoming on the left. So very strong partisan reaction. And there was also partisan relation to the vaccines. In the book, we're not skeptical about vaccines. The vaccines made a difference. Our argument is that we lack evidence in terms of mortality for the effectiveness of these non-pharmaceutical measures when they were implemented. In other words, Republican states did have higher death rates from COVID after the vaccine was available, but not before, once you correct for things like age, percentage uninsured, percentage urban, and a whole variety of other factors. But in any case, so vaccine uptake, also strong relationship between Democratic vote and vaccines. With what results? Vaccine uptake did lead to lower death rates in Democratic states after the vaccines were available. No question about that. The evidence shows that. But all of the other measures, lack of support. Faster stay-at-home orders not associated with COVID mortality. Lengthier stay-at-home orders not associated with COVID-related mortality. Longer school closures not associated with COVID mortality. All pandemic restrictions not associated with COVID mortality. So no relationship in terms of empirical results as opposed to modeled projections. And there's county-level data that validates this at the county level. Again, when vaccines become available, Republican states trend upward from Democratic states, but not before. Thomas Bolecki's work does support ours. He shows that there are reduced infection rates in Democratic states, that the NPIs had some association with reduced infection rates, but he lacks evidence that they reduced mortality. And we don't think reduced infection rates is sufficient to justify the costs of the measures if in fact there was no impact on COVID mortality. And just to say, Posado et al., the best study that's available, we think, of the European countries, 29 European countries, greater variation in European countries in terms of the stringency of these lockdown measures as opposed to the American 50 states. No relationship there. The authors of this article find in terms of excess mortality, the average of the previous 10 years. They express surprise at the lack of association between more stringent lockdown measures, the lack of association between those and mortality. What about the costs? That's the other side of the ledger. Sara Cody mentioned that the mandate of public health and California law is to do what you can to reduce the spread of a virus. But what about the costs of the measures that are undertaken to slow the spread of the virus? Effects on education have been large and persistent. Unprecedented drops in student learning in both reading and math, reversing roughly 2 decades of progress. And the losses are greater in high poverty and Black and Hispanic students. Chronic absentee rates from schools have doubled, now at 1/3 of K-12 students. And these negative impacts on schools and school children were predicted. Pandemic relief was just huge in terms of the amount of GDP and the amount of debt imposed on future generations, equal to the entire New Deal, 5 years of the New Deal, and the 2009 financial bailout put together in 2020. And then we did the whole New Deal over again as a percentage of GDP in 2021. Contributing to inflation and probably the change of governments in many countries around the world as well. Crime, the largest year-over-year increase in homicides in U.S. history. Surge concentrated in cities with more young men forced out of work in low-income neighborhoods. 40% increase in firearms sales, carjackings way up, and so on. Inner cities, of course, San Francisco is sort of rebounding a bit now, but it's had years of seeing downtown areas degraded significantly in terms of businesses and foot traffic and so on. Effects on physical and mental health, delays imposed on non-essential elective care, rise in excess deaths, even demographics little affected by COVID, surge in anxiety, depression, eating disorders, measurably higher in counties with mandatory social distancing, increase in substance abuse, overdose deaths, depression, and so on. Depopulation of downtown business districts, depressed church attendance, loneliness, social isolation, and so on. The costs of the measures themselves were severe, and these were predicted. and physical and mental health, of course, the loneliness and isolation of people in nursing homes who weren't allowed to see relatives, significant psychological and emotional suffering, which we document in the book. Any lessons learned? Well, the Scottish COVID inquiry said, and it's a good one, that we lacked evidence for the effectiveness of these non-pharmaceutical measures at the beginning of the pandemic, and we still lack evidence for their effectiveness. We just don't have evidence in terms of significant reductions in mortality for the severe measures that were put in place. There was not really any political price to be paid because governors pursuing very different strategies won re-election. The voters don't seem particularly have noticed, though there's been a considerable drop in confidence in public health among Republicans in particular. And just to quote Francis Collins, this is getting to the end here. Respecting public health, the head of the National Institutes of Health, the major health funding agency in the world, his own reflection on the pandemic was this: if you're a public health person, you have this narrow view of what the right decision is, and that is something that will save a life. It doesn't matter what else happens. So you attach infinite value to stopping the disease and saving a life. You attach a zero value to whether this actually totally disrupts people's lives, ruins the economy, has many kids kept out of school in a way that they will never quite recover from. This is a public health mindset, and I think a lot of us involved trying to make those recommendations had that mindset. And anyway, there's much more to be said. I'll skip this last one, but there are questions around the origins of the virus and so on that still haven't been answered and so on. But I will leave it at that. In retrospect, I think we need to continue our careful reassessment of what happened. Decades of pre-COVID pandemic planning had the general view that these non-pharmaceutical measures were unlikely to be effective and would be extremely costly. It seems to us, authors of this book, that the balance of evidence suggests that those pre-COVID pandemic planning documents were correct.
Thank you both. So Sara, I'd like to give you a chance to respond to some of what Steve just brought up.
Now is it on? Great. Well, that was fascinating. I have a lot to say. I'll just try to pick a few things. First, I would say, and this is a lot based on my experience as a public health professional on the ground, we spent all these years doing pandemic influenza planning, and then when COVID hit, we looked back at our plans and said, these aren't really relevant because this is a very different virus. We had had a little bit of experience with coronaviruses, SARS-1 and MERS, very high case fatality rates. And so we didn't know, there were so many unknowns about how this new virus would behave. And the early information was that the case fatality rates were significantly higher than anything that we ever saw in flu. So I can remember a whole bunch of folks from the city of San Jose anxious to get our pandemic flu plans so they could know what we were about to do. And we said, you can have them, but it's not really going to help because we didn't consider, in broad strokes, some of it was useful, but a lot of it really wasn't useful. So I think that's quite significant. I would imagine that other public health folks felt similarly. And in fact, early on, I guess after we had our first case of community transmission, there was a whole team from CDC. Actually, they came out, because we had early activity, they were coming out to support and to learn. And part of what they were doing was developing community mitigation strategies because the CDC didn't have a community mitigation plan for COVID at that time, just to give a flavor for how dynamic it was. The other thing I just wanted to say about decision-making under uncertainty, of course, I was concerned, and I felt that I had a moral duty to prevent death if I had the power to do it. That's not to say that that's all that we were concerned about. And in fact, there were many discussions, and I think we said this publicly quite a lot in the Bay Area, that what we were struggling to do was to chart the most health protective path forward. Because part of your public health training is all about the social determinants of health, and economic inequality and poverty and discrimination, they all impact health. The problem was, in a local health department, if you're the decision maker, you don't have those data feeds. One, it's not real time. Two, you don't have access to it. And it was an enormous struggle to try to guess what the short, medium, and long-term health impacts of a decision were going to be in order to balance it with the decisions to limit COVID transmission. That was an enormous challenge, and that was threaded throughout the pandemic. And then just one final comment, and then I'll turn it back. Consider the unknown unknowns. So we had the known unknowns. We knew that we didn't know much about this virus. We didn't know how it was going to behave. We didn't know all of this. But there were the unknown unknowns. Long COVID. No one in any of these articles and models mentioned long COVID. Long COVID has had a huge individual, family, social, community, and economic impact worldwide. It's like the long, invisible tail of the pandemic, and that's not in any of the models. And then if you have a conclusion, you can find a model to fit it. It's, as far as these retrospective looks at the data, it's incredibly, incredibly complicated, and I have a feeling that some factors that actually drove some results are not accounted for, and we can talk more about that.
Thank you. And there are a lot of uncertainties and a lot we still don't understand for sure, without question. But we have 4 critics in the Boston Review. They looked for evidence of reduced mortality and did not come up with it. They cite the Bolke study, which shows reduced infection rates, but that's not associated with significant decreases in mortality. So I don't think there is good evidence of significantly decreased mortality from the NPS, such as evidence that's available. The evidence that's available is at 30,000 feet, and more fine-grained evidence might show something different. But given the evidence base we have, I actually don't believe it's the case that it's all that, because the people in the Boston Review who push back against us don't cite any evidence of reduced mortality. The other thing is, I think there was a lot we didn't know at the beginning, but for example, Jay Bhattacharya tried to do a seroprevalence study to figure out how many people in the population had been exposed to COVID and not gotten particularly sick, and so try to figure out the actual infection fatality rate rather than the case fatality rate of people showing up in hospitals and so on. And got a lot of flack for that. And the government never did, the CDC and so on, it's not your fault, but the government really never did good seroprevalence studies, so far as I know, to try to figure out how many people in the population had been exposed but had mild illness or no symptoms at all in many cases. So we should have, there's more that we could have learned early on. And then finally, there's a very good book by David Zweig called An Abundance of Caution that focuses on the schools. And it's came out a little after our book, it's complementary to it, I think it's terrific. He shows that in Europe, many schools reopened in April and May. Many schools in the UK, France, and Germany. The European education ministers put out a statement in early May 2008 or 6th, 2020, saying our schools have reopened. They're not proving to be spreaders of disease. They can reopen safely, and so on. European schools in general, many of the Western European schools were reopened in the fall of 2020. Republican state schools were reopening in the fall. We were ignoring evidence that was available. The other thing is that the modeled projections coming out of Imperial College London and elsewhere were being proved wrong over the summer. They predicted that if Sweden didn't close down, they would have 40,000 deaths by July. That was just shown wrong. They had something like 1/10 of that number. In another case, there were few governments in the world that didn't engage in these measures, but when they did, they showed that the projections coming out of the Uppsala model or the Imperial College model certainly were incorrect. So I think there's a lot more we could have learned if we'd been more open to learning. The news media didn't report these results from Europe. They reported bad news about COVID when it was available, but not good news. The CDC put out a report in April saying there's bad news and good news. The bad news is that African Americans and males are more vulnerable to COVID than women and others, but the children are at very low rates of mortality from COVID. And Zweig shows that the media widely reported the bad news, but not the good news, that children were at very low risk. I think part of it was that Trump was on the ballot, and people were afraid that if he, if he turned out to be right about anything, that would be bad for Democrats' election chances. And I think that was some of what was going on. The suggestion that the virus might have leaked from the lab once it was associated with Republicans was not going to be taken seriously. So I do think that I think that there was much uncertainty, and I totally sympathize with those who had to make decisions, as you did, under the conditions of this uncertainty. At the national level, I think we could have done more in order to learn from the experience of other countries and to have engaged in incremental progress along the way. I'll just say that Graham Allison at Harvard, a scholar of crisis decision-making, put out a document in April 2020 arguing that we need a team B, we need to re-examine our assumptions, this strategy that we're doubling down on, it'll be costly and we don't know if it's the right one, we need devil's advocates and so on. And so far as I can tell, that recommendation was completely ignored. We adopted a strategy, we stuck with it, and to a great extent, we stigmatized those who dissented.
All right, I want to ask you both about decision-making under uncertainty. Stephen, your account, you are basically saying we knew what state of the world we were in because we had planning for past pandemics, and this pandemic is like the past pandemics. But what I'm hearing and what I understood at the time was we actually didn't know that we were in the same state of the world. And so you're in a state of the world where you don't know what the boundaries are or what the consequences are. The stakes are really, really high, and there may be path dependence. So once you go down a route, it's really hard to pull back from that route. So I want to ask both of you, what principles should a decision maker use under those circumstances? You can talk about learning, from what we've learned now, and we can talk about whether, given that, there should be adjustments. But at the time, there was no learning, and there was some evidence, at least from what I understand about Italy, that some degree of masking and quarantining was helping. Whether that was, in the end, right about the mortality statistics, that's what people were thinking. So what should you do? Do you go, minimize risk to zero? Do you, how do you factor in all the other factors? What should a policymaker do?
It's a great question, and it's certainly the position in which we found ourselves. And the way I thought about it was we have to go, first of all, you have to sort of look at how quickly things are happening and how quickly things are changing and how much time you have. What we understood in Santa Clara County is that we didn't have time. The doubling time was every 2 to 3 days. And if we took action later, we would miss so much of the benefit and we would still have all the harms. So I think that's actually one of the problems with some of these models is they don't take into account timing, the local epidemiology and the policy and how those two work together. So I think that at the outset, you need to do something fairly big and bold to buy yourself a little bit more time while you get other modalities up and running. Evidence and things, testing, masks, workforce, all these things that we didn't have, and as well as input. And I would say that was really quite difficult. Perhaps for some of the reasons that you state, everything's quite politicized, but also you have to have those structures in your local community already in place where you have a wide variety of people that are giving you honest, unvarnished input, to the decision makers, so that you kind of have a two-way flow. And in order to have that, you have to have established that beforehand, and there has to be a pretty high level of trust. And I think that was incredibly variable across the country, what that looked like. And so then you would go sort of in stepwise fashion, turning some things down and bringing other things on. And hopefully you wouldn't get stuck in these path dependent where you felt like you had to stick to your guns for political or other reasons, even if you had information to suggest that you should change course.
Yeah, the one thing we needed to do was to think about the costs of these measures that were being imposed and not focus simply on the one variable of potential deaths. The costs were predicted to be severe. Paul Peterson at Harvard, who's an education scholar, published a piece on his journal, which quickly disappeared from the web because by April 2020, social media companies were censoring information that didn't support the collective narrative. But in any case, he looked back on previous teachers' strikes and blizzards in which schools had been closed for weeks and found that there were significant detriments for children's well-being, not just learning, but emotional well-being. And so these costs were predicted to be considerable. Business closures lead to, loss of employment leads to lifelong detriments in terms of people's well-being, not just short-term economic loss. So, and this is why D.A. Henderson said that societies respond best to pandemics when they're least disrupted. People will engage in voluntary social distancing. People did that in Sweden, and I'm sure that's part of what contributed to their relatively good outcome. They engaged in voluntary measures. But it's not clear that the mandatory measures were justified. And the other problem with the interventions is, we've known since the 19th century that pandemics come in waves. There's a natural falling at a certain point, and there's really no good association that we know of between the interventions that were imposed and the declines. Mark Woolhouse, in his book, The Year the World Went Crazy, Scottish epidemiologist who advised both the Scottish and the British governments, said he thinks in retrospect the infection rates were already coming down when the first lockdowns were imposed in the UK, and he doesn't think any of the subsequent lockdown measures had a significant impact on the waves of the virus as it proceeded in the UK. So we need to pay more attention to the cost of the measures and not just the hope that they will save people's lives.
I just want to pipe up about schools. The decisions to close schools and to keep schools closed were by no means the public health people saying, we think that schools are a risk and therefore they should be closed. In fact, fairly early on, and I'm just speaking Bay Area, California, the initial concern about schools was that for pandemic flu, school-aged children act as amplifiers. And so it's really important to not have school-aged children gather because you get amplification and then spread into the community. We were pretty clear early on that is not the pattern we were seeing with COVID. And the problem was that there was such a division, people adamant that schools be open, people adamant that schools be closed, and schools had control, the superintendents, about whether the school was open or closed. There is no public health official that could compel a school to open. So it was labor forces, many other forces were at play that kept schools closed. It was not a public health decision where public health said, I think that this is, on balance, the right thing to do. And that's a narrative that's out there, and it needs to switch. I regret that I didn't put more elbow grease into advocating for schools to open. We had a whole plan in Santa Clara County for school reopening, ways to mitigate risk, et cetera, et cetera, et cetera. And we couldn't get it through. and I was sort of added juice to take more, sort of to carry more water. So, and I don't think that's an uncommon experience.
No, I mean, it was,
Yeah.
that sounds entirely right to me. Michael Hartney and Leslie Finger are two political scientists that have written on this, and the frequency and length of school closures is strongly related to the Democrat vote for president and the strength of teachers' unions, not the virulence of the pandemic. So
The latter.
that's very much what the evidence shows. And unfortunately, it was a mistake. And again, the news media wasn't reporting this evidence coming out of Europe. Their schools being reopened, people didn't want to hear contrary narratives. And again, it was predicted that the outcomes would be worst for poor children, and that seems to have been the case.
So two quick questions, and meanwhile, I think probably people should line up at the microphones so we don't lose more time with that for you, your chance to ask questions. One is, just to clarify, lack of knowledge about whether non-pharmaceutical interventions worked is not the same as that they didn't work. It just means we didn't know one way or the other, right? And then secondly, we've been focusing on deaths, but there are, even before we knew about long COVID, there were serious long-term illnesses based on, as a result of COVID. And shouldn't that be factored in rather than just mortality?
Yeah, as Sarah mentioned, long COVID, which is not well understood. There's no common definition, I believe. And other viruses have sequelae as well. And some people have said that the rate of long after effects from COVID is not higher than previous flus. But long COVID is, it does exist, and it is something that has to be taken into account. It's not well understood, it's not well defined, and it's not well studied. But it does exist, and it exists with other viruses as well.
There's actually a great review published in Nature on long COVID with mechanisms, different phenotypes, global burden, prevalence. It's quite good, and it's quite distinct from at least as far as the prevalence from chronic conditions after other viruses. And the prevalence is estimated to be pretty high. It's I think maybe one of the reasons why it's not included in the models is that landing on case definitions to really understand it has been an enormous challenge, and I think that kind of set it back. But I think that the impact is quite large economically and just in terms of cost for the healthcare system. People developing diabetes and cardiovascular disease as a result of long COVID, and then requiring extra care.
We should put the poll back on. Can that be?
So the first, before the conversation, the answer to yes was 73%. It's now gone down to 57%. And the no's have changed proportionately.
Okay, we have a bunch of people lined up. I have one more question, though. I'm just going to quickly, but very quickly. I mean, if reading through the material and thinking about, actually, if you think about what we could have done to be better prepared for COVID, it would be not to have so much concentrated poverty. It would be, to have better employment options and better education. And there's a lot of the vaccine obviously was critical, but it's not the only factor that explains the death rates.
Age is the biggest one, and I don't know if this is still the case. David Siegenthal, a British statistician, calculated that basically your chances of dying from COVID were your chances of dying in the next year, just packed into 2 or 3 weeks. But age was the largest one. but better healthcare system and better availability of healthy food. All of the usual suspects, I'm sure, would have been helpful as well. And I'm strongly in favor of universal health care and lots of the other measures that you would favor.
I think the role of trust is incredibly important, and I was happy to see in that article that there was some attempt to measure it that is consistent with our experience on the ground, in that communities where we had developed a high level of trust, they felt more comfortable telling us about things that weren't going well, and we listened and could pivot. And same when we said, this is a risk, this is a problem, we're worried about this, they believed government. So I think that as far as an action item, while it's difficult to change all these social determinants of health, there are things that local governments and communities can do to build relationships and to build trust that are health protective in the future. I think there's good evidence for that.
Oh, and we should put up the attendance. Sorry. And if you just check in. All right, maybe we should take the first question.
Can we get the attendance slide?
Oh, okay.
Well, thank you very much for this thoughtful discussion and retrospective. I think it's really important to understand what happened, so we're perhaps better prepared for the next time. I wanted to ask about sort of the unintended consequences that perhaps were positive, that demonstrated that policy can, in fact, turn on a dime. Some of the effects that I'm thinking of are sort of the move to permanent hybrid work, and there are effects on downtowns, but there's also effects on the commute, right? And carbon, right? From people driving or changing like the ways that we work. And maybe the jury is still out on whether that's positive. But another one that comes to mind is the change in ways that we use public spaces. And so sort of a snap decision to close streets or make more spaces open to public use. I think because of COVID policies, people were more willing to try some of those things. And they have proved, at least where I live, to have been transformative and net positive. Perhaps you could speak to some of those and ways that we can be more open to things like that coming out of a difficult moment. Thank you.
Those are terrific examples. I don't really have anything to add, but there were a few rays of light from the pandemic.
Yeah, I have to concede that as well. Every disaster has upsides. Zoom, yes, for some meetings is better, and there are various concerns. I don't know any evidence to suggest that like social capital in general has improved as a consequence of COVID. We're social creatures. The response of isolation, I think, has very detrimental effects on people's psychological and physical well-being. Just simply the isolation of old people in care homes and so on, I think was horrible. Having to have weddings postponed, funerals postponed, and so on. I mean, you're right. There are some positives for sure. And during COVID itself, I mean, nature, flourished. Planes weren't flying. You could hear the birds, and animals came out, and there were still foxes on Princeton's campus and so on. So, there are various positives you can mention, but on the whole, I think our social lives deteriorated under COVID, and I think young people in particular have suffered as a consequence.
First of all, thank you guys so much for allowing us to do something like this. We're all very privileged to, have this opportunity to have these fantastic discussions. I have two quick questions. The first one is, we live in a society where there's a lot of misinformation, a lot of disinformation, and it's important during these times of disaster to have an element of control. President Trump at one point advocated drinking bleach, I believe it was, as a measure of preventing COVID. So how do you have discussions? I know you brought up Jay Bhattacharya's Great Barrington Declaration. How do you bring up these ideas of discussion that are somewhat, it's important to have two sides of the argument without also weakening social constructs and this social buy-in, this social trust between people that's really important during these very stressful times. And then my second question is, the healthcare system was very strained during this time, and although NPIs did not have a super direct effect on mortality, they did have there's a lot of data that does suggest they had they did have a big effect at suppressing infection. How do you account for the overwhelmed hospitals that would have occurred if these NPIs were not put into place? I had two parents working in the ICU and OR, at the beginning of COVID when it was, already really bad, and it would have only been worse if those infection rates had gone way up. So how do you account for the, increased mortality that would have come from not having those NPIs and having, hospitals that couldn't account for those high infection rates, like those condensed infection rates? Thank you.
So thank you for both of your questions. I'm going to focus on the last one. I just want to state for the record that that Steve has mentioned a lot of studies that show that there's not an effect on mortality. I don't think that that's the take home. I think that you can pull studies that show that shelter-in-place orders and many of the other non-pharmaceutical interventions, most particularly masking, did prevent infection and death. So I think that there's just a lot of nuance and a lot to be discussed about the quality of evidence and how it's interpreted. And I think it's going to take a long time to untangle it. One of the drivers of shelter in place in the Bay Area was that we were looking at hospital capacity and we were running out. And so if you have a cohort of patients that are on a chemotherapy regime that are going to need a hospital bed, you have a cohort of patients that are already scheduled for particular surgeries that they really need. And we wanted to be able to preserve hospital capacity for everyone and every illness, and our projections were showing that we were gonna run out. And I think that was a driver in many places. And I will say, New York actually had case growth that lagged ours initially. I was in close contact with a health officer there. The day that we had 9 cases, they had 1. I can't remember, some day in early March. They could not implement a shelter in place, and so their doubling time was much shorter than ours at the time that they did implement it. And they overshot, and I think we all saw what that looked like. So yes, hospital capacity is a very important consideration.
Yeah, I mean, I do think there was a case to be made early on. As I said, Mark Willhouse has concluded in the UK that cases were already dropping and that lockdown measures didn't have a major effect. Look, open table reservations fell off a cliff before any measures were imposed. People were engaged in voluntary social distancing. So one question is, how much difference did the measures make? 1/3 of workers had to keep working during the pandemic to keep the rest of us with the lights on, food being delivered, electricity, internet, wine and beer, and so on and so forth. So for 1/3 of workers, that was never going to be possible to work remotely. And these social distancing, really, I don't think we have a chapter on masking. I don't think there's good evidence there. Zeynep Tufekci cited 2 studies in a New York Times piece, both of which were corrupted, and she was incorrect about those. So at the population level, mask mandates, no, we lack evidence, as Paul put it, that mask mandates work. And indeed, the surgical masks are not recommended for preventing the spread of respiratory viruses. It says that on the package, actually, with many of them. Just on the misinformation point, we have a section of the book on misinformation, an article published in August 2023 in a medical journal, I forget which one, arguing that doctors should be punished for putting up misinformation around COVID on their social media feeds. And that misinformation included that the virus might have leaked from a lab in Wuhan, that natural infection and recovery is as good as getting a shot, that after getting the virus, that the vaccine didn't protect against reinfection and disease and so on. So a fair number of things in the article argue that doctors should be punished for misinformation was itself misinformation. I just don't think, the whole premise of this event is there's a lot of reasonable disagreement out there and a lot of uncertainty. And I don't trust the government to be deciding the truth for the rest of us, or authorities, frankly. And we just talked about teachers' unions and schools. Those are also authorities with respect to schools. So I think that we have to let debate go, and people will say stupid things. People have been saying stupid and irresponsible things for a long time. I don't trust governments to be deciding, what the truth is and what truth is. And what we're seeing, an experiment working in Europe now with respect to a much more stringent speech restrictive regime. I'll take the American model personally and say that social censure is one thing, but no, we shouldn't have the government punishing what it decides is misinformation. The record under the Biden administration was not good. It included stories about the Hunter Biden laptop and other things that were political, not COVID related.
Thank you.
I just want to respond about the evidence of masking. I think there is really, really good evidence for masking. And
in hospital settings or elsewhere?
Community and hospital. Dose response. A cloth mask doesn't work so great. Surgical mask is slightly better than a KN95 and then an N95. It depends on dose, duration, and type. But it's quite protective. There's also community studies and studies around mask mandates, and they all support the effectiveness of masking, and I'm happy to share a very recent review. And I think there was a big Cochrane review on masking, and that may be one that you're familiar with. Yeah. It was just limited to randomized controlled trials, excluded every other kind of evidence. And so the conclusion from the media was masks don't work. And actually the editor of the Cochrane Review came out to say that is not the conclusion of the evidence that's presented. But that particular review took a life of its own because the Cochrane Review is quite highly respected.
Yes, but the editor had to withdraw that statement. Subsequently, that statement by the overall editor was withdrawn. The observational studies do show these sorts of things, but the most rigorous studies don't show it. And surgical masks are not for preventing the spread of respiratory viruses. N95s are very hard to wear. I mean, how many people wore N95s conscientiously, changing them frequently, the way that people do in hospitals? They're typically individually fitted and so on. Just the ordinary people are not going to wear masks for lengthy periods of time. Properly. Even N95s are 95% effective at best. So, and also for particles, I think that are larger than. But in any case, we won't settle this here. But
I'll give you my article, Steve.
Okay, absolutely.
Hello, thanks so much for coming here, Sara and Stephen, and speaking to us today. My first question was answered by the previous asker and you too. And so my second question is, in hindsight, what is one thing that you believe governments and also individuals should have done differently in regards to the pandemic?
A pretty long list. I don't think that in the United States our various levels of government worked well together at all. I felt as a local person that I expected the federal government to kind of have some sheet music that we could all sing off of, and that they would be in contact with their international counterparts to be gathering information and help us understand the state of the changing evidence, and that didn't happen. And while I think that our federated system is fantastic because you can adapt locally to the needs on the ground, confronting a global respiratory pandemic, 3,100 different ways across every county really was absurd. So I think we have some government structure problems, and I'm sure you have a very, very long list.
Well, I just think we could have learned from experience as it was unfolding. The Swedes were predicted to have a very bad pandemic, and they did have a higher mortality rates early on compared to some of their Nordic neighbors. They'd had a mild flu season the year before. But as I say, the schools reopening in Europe provided powerful evidence. There were other kinds of evidence that would have been powerful about some of these models and so on. And so we weren't learning from experience. We weren't learning from Republican states having their schools open and so on. Things were highly politicized. So I would say listening to dissenters and respecting those who have different points of view. Remembering the fundamental values of liberalism in science, which is that, when people, even when Scott Atlas was censored here, the censor motion said what he was arguing was at odds with the preponderance of the evidence. Well, the preponderance of the evidence is more than 50%, a little over 50%. Since when do we think that those who have a minority viewpoint should be censored? So don't censor. Now, the problem in public health is you need everybody to go along. You need everybody to be on the same page. So I think there may be illiberal tendencies built into public health. The head of public health at Boston University wrote a book called Towards a More Liberal Public Health, Sandro Galea, and he issues a kind of indictment of his own field for being politicized and not open enough to dissent. I'd highly recommend that book, Towards a More Liberal Public Health by Sandro Galea, who's moved on to Washington University. I don't think we lived up to our own I don't think educated elites lived up to their own fundamental values of respect for disagreement, dissent, and willingness to learn. I think some of it was politicization, partisanship, and the sense that we all needed to be on the same page for the strategy that was settled on to work.
Thank you.
One more on this side before I go to that side.
Firstly, I wanted to thank you all for a great discussion. I actually had long COVID for about a year and had to redo my junior year of high school because of it, so it was very interesting to hear the discussion surrounding it. I was wondering to what degree the unknown long-term effects of COVID went into public health decisions once the news came out of long COVID patients starting to appear.
Well, we didn't have information about long COVID when we were making our initial decisions, but I think that's one of those where when you ask in retrospect, trying to understand the impact of the policies, whether right or wrong, we did need to account for long COVID. The best way to prevent long COVID is to prevent COVID. And the risk goes up with the more infections that you have. So not getting infected in the first place or being vaccinated reduces your risk of long COVID. And long COVID is, better than I, is not just costly to the person, but caregivers and the healthcare system, and the burden is quite high. So I just mentioned that because that was an example of an unknown unknown. That when you're making a decision under uncertainty, you don't even you don't know the bad things that you're preventing, nor do you know some of the bad things that you may be causing with your decision.
Hi, thank you all very much. I wanted to just drill in on the point. I know we've talked about this theme a lot across our conversations, but really a theme between promoting a liberal conversation and disagreement versus decisiveness in a time of crisis. Because from my understanding of our key crises in American history, I'm thinking mainly a war scenario. There's a big emphasis on uniformity and unity under the same banner, and just everybody getting behind the same side to counteract a problem. But how do we balance this with a liberal tradition and possibly changing those viewpoints in the midst of a crisis?
I think that something that was very important and sometimes lacking during the pandemic was being absolutely honest about what we knew, about what we didn't know, and also continually expressing that things were going to change. What we knew and what we thought it meant was going to change, because it's true that it's helpful to have everyone united and together and doing the same thing, but what we needed people to do changed. And I don't think that we did a very good job asking people to anticipate that what we were going to say was going to be different, and that we would all sort of have to ride these waves together, and that things would change.
Okay.
I mean, I would say that I think there was a strong action bias. The public doesn't want to hear, we don't know, we're not sure, maybe we shouldn't, impose these strict measures that Italy has imposed and others. I think there's no question that countries imposed these strong lockdown measures because they saw other countries doing it. They were popular. Countries tended to implement these measures when neighboring countries tended to implement them. It had much less to do with the stringency of the virus. So I think there's a strong action bias, unfortunately. I think the pre-COVID pandemic plans were meant to push back against that in part, to impose some humility in terms of our lack of knowledge, and again, to emphasize the costliness of these measures. It's not as though they were going to be costless. So I think the wartime metaphor was unhelpful. I think that it was an encouragement to groupthink and doubling down. What will happen in the next pandemic, I have no idea. It may be similar. It is strange that the World Health Organization issued this recommendation based on their 1 week experience in China. Then Italy demonstrated that a democratic society was willing to put up with these measures, which I don't think had been anticipated before. I don't think the previous models ever anticipated the implementation of measures on the scale that was undertaken, because I don't think they ever thought that it was possible to impose. And actually, before the internet arose and so on, and people were able to work online, it wouldn't have been possible. So it was a novel measure. We need to study the costs of the measures that were imposed, because by focusing on the hope for disease prevention, for which we lack evidence, I believe, we're in danger of ignoring the many costs that were created by the measures.
Okay, thank you.
Hey, so I think at this point, people have talked a lot about the non-mortality effects of COVID, whether that be diabetes, whether that be cardiac or respiratory issues, whether that be long COVID, that there are these kind of long-term externalities to allowing COVID infections. I'm really curious, especially because you guys had talked about how symptoms escalate, and especially mortality, risk of mortality escalates greatly with age and at high-risk populations that would already be quarantining. So I'm curious how you think that kind of distinction between those externalities that maybe affect the more general population and the mortality that is primarily isolated, or not entirely isolated, but mostly isolated to these high-risk populations that are able to self-quarantine, affects your comparison of the cost of doing these kind of strict infection prevention measures. Especially when you look between states that took a more general, like lockdown, prevent infections on a wider scale approach, and states that were maybe more focused on a specific subset that were already high risk. And if you think that those externalities affect your predictions or your comparison.
I mean, I do think that many places did not do a good job of protecting the vulnerable. Sweden didn't. The East Asian societies may have done a better job of that, but lots of places, certainly New Jersey and New York, did not. I mean, they moved people from hospitals into care homes with COVID, and we did not do a good job of protecting the most vulnerable. I think that's for sure. Countries, Sweden, over the course of the pandemic, had negative excess mortality. That is, they had fewer deaths than would have been predicted otherwise. There are several other countries that had that as well. I do think long COVID, as Sara said, we don't really have a good, steady definition of it, so it is hard to study. And there are puzzles associated with it. The symptoms overlap considerably with depression. And I don't think we understand. But there are sequelae from pathogens, and the problem is with an unknown. What do we do? We have to put up with some of the risk, or else we should still be masked and socially distanced at this point, since there are, unfortunately, these long-term effects, but some risks we have to put up with for the sake of the valuable things in life that involve contact with other people.
I think that the risks changed over time in many ways that we couldn't anticipate. For example, the initial variants that were circulating caused much more severe disease. And then later, after about 8 months, they were more transmissible or easier to evade the immune system. And so there were different risks there. Basically, I always felt that we were in this dance with the virus. There were the behaviors that we were taking, and then there was sort of the behaviors of the virus that was changing at the same time. So it was very dynamic. I think that there, as Steve said, a huge variety in how different communities were able to protect most vulnerable populations. The more kind of general transmission of COVID that you would have in the environment, the higher the probability that a vulnerable community, like in a long-term care facility or in a carceral setting, would be infected with COVID, the greater that was, just sort of an idea of probabilities. So I didn't ever sort of see how this idea, I mean, it was a great idea to discuss of focused protection. I didn't see how it could ever work. Also just because of the structure of society, that people who are vulnerable live with people who aren't. People who are at great risk of bad things happening live with people who are out in the community getting exposed. So I could never figure out how you would pull that apart to protect a vulnerable group. And sometimes it was hard to know whether you were vulnerable or not. You know, there's other categories apart from age.
Appreciate it.
Okay, we really are out of time, but we'll take one last question very quickly.
Hi, and thank you. It sounds like there's sort of a consensus between you two that the most important intervention was getting the vaccine available to people, which makes me wonder if maybe the policy issue that had the greatest expense is actually the sort of hidden policies that delayed the vaccine. For example, would it maybe make sense to do a larger combined stage 1 and 2 clinical trial where we have a lot more people take it with the risk of some side effects if there are side effects, but also then we get evidence of efficacy right away so we can get it out to the population months earlier than we actually did?
I mean, I think that this was a record-breaking vaccine development and was one of the, crowning achievements of the work during the pandemic. I can't think of another example of a vaccine that was developed that quickly to a novel pathogen. I think that there's two things, though. There's the vaccine and getting the vaccine ready, and then there's vaccination, getting the population ready to receive the vaccine and to trust the vaccine, and those are two very, very different things.
Yeah, I think that's completely correct. There were some claims made that we might have developed a little faster. The head of one of the drug companies did brag subsequently that they delayed some of the test results until the week after the election. That obviously wasn't a substantial delay, but it was perhaps a significant one. But in any case, yes, I think Operation Warp Speed was a success, and we're still studying the vaccines and the issue. Some side effects were played down, I think. Paul Offit has offered some very interesting, he was on the vaccine advisory committees, and he's offered some critical reflections on their deliberations. I think some of the recommendations for boosters, and we were recommending them, everyone over the age of 6 months, when Europeans were recommending them for those over the age of 65 years old, those may not have been well justified, but the vaccine itself does seem to have been a game changer, and perhaps it can be sped up in the future.
Thank you.
All right, please join me in thanking our guests for a really wonderful discussion.